Somebody help me.
Sarah, I think you're still on mute.
Oh, Sarah?
Yeah, am I
No.
unmuted?
Oh, now I hear you.
Okay, sorry everyone. I think I got a little too carried away with staying alive. I was just saying it's better for me to keep my day job. But all joking aside, I want to welcome everyone and thank you for joining us for our monthly Geri Echo. My name again is Sarah Tompkison, and I'm a social worker. This CME activity is jointly presented by the Queen's Medical Center and John A. Burns School of Medicine, the Department of Geriatric Medicine. Joining me this afternoon is our interdisciplinary Geri Echo team, where we're all willing to teach and share our collective experience and wisdom with you. Today joining me is Courtney Nunokawa. And as a reminder, if you do want to get CEs, social work CEUs and CMEs, you can find the evaluations by following the link in the chat or at any time on our website and email advertisement. And that's the only way you can acquire the CMEs and CEUs. Additionally, we do value your comments because it's helpful for us in planning for future programs. Just as a friendly reminder about ECHO, we want to emphasize that this ECHO webinar is a forum for mutual teaching and learning from experts and from each of us on the front lines. As our ECHO motto goes, all teach, all learn. So it will take all of us to create a community of learning. Today, our format consists of a short lecture from our expert presenter, with open comments from the expertise of the ECHO Hub team. And you, the participants, we equally value your comments, your questions, your case presentations. That's how we best learn. And we do encourage you to talk, not only share about geriatric cases, but any other questions or comments you have. Lastly, we ask that you please keep all case discussions HIPAA compliant. This includes not sharing the patient's name, birthday, address, and so on. We learn best from our patients and our clients. They are our best teachers. So this afternoon, it gives me great pleasure to introduce our speaker, Dr. Aida Wen. She's an associate professor with the Department of Geriatric Medicine, John A. Burns School of Medicine at the University of Hawaii. Dr. Wen is currently also the principal investigator for the Geriatric Workforce Enhancement Program and is the program director of the Geriatric Medicine Fellowship Program. Her biggest strength is that she continues to be an advocate for improving both geriatric and dementia care while striving to help patients, their families and providers, and our seniors age as gracefully as possible. Welcome, Dr. Wen.
Thank you so much for your kind introduction. I am excited to talk to you today about delirium, recognizing and managing delirium. Let me share my screen. Here we go. You got that? Great. Okay, so let me just move things around here. Okay, great. Okay. Okay, so our learning objectives today is to be able to use different delirium assessment tools, know the common causes of delirium, understand how to manage delirium behaviors, and be able to manage and prevent consequences of delirium. Okay, so here's a very common case scenario. It's Friday afternoon. Mrs. L's daughter calls about her mother. She is refusing her meds. She tells you it's poison and throws her glass of water and demands to be let out of this prison and threatens to call the police. She has been eating less for a few days and refused breakfast this morning because she wanted to sleep. She has had difficulty answering questions, and this is not like her. So let's take a look at some of the features of delirium. And this is from the CAM, the Confusion Assessment Method. So one of the first features, very important feature, is that it's acute onset. It's a sudden onset, or it's fluctuating. So this is a new behavior. This is not like them that you'd notice in the last 24 to 48 hours. And there is a change in their consciousness, attention, or their thinking fluctuates during your interaction with them. A second feature that's really important for delirium is inattention. They're very distracted. They have trouble keeping track of conversations, and they can't follow directions. And then other features include feature 3, which is psychosis and disordered thinking, or a change of consciousness, change in their level of consciousness, like their sleep-wake cycle. So for psychosis, that includes things like seeing things that aren't there, hearing things that aren't there, or delusions, which are like paranoid beliefs, and believing firmly in something that is not true, in spite of evidence right in front of them that they can see. Disordered thinking is part of psychosis as well. And, they might be thinking like confused, like they think you're her husband, or their speech is rambling, going off in different directions. It's unclear. There's no logic, no flow. Either that, or maybe their speech is very limited, or very, very limited, very little speech at all. And then the level of consciousness would include things like being hypervigilant, such as being awake all night and restless, keeping the whole house awake, right? Or falling asleep when you talk to them and sleeping all day. So I think a lot of you find it's easy to recognize hyperactive delirium because of these features. I mean, they really cause a lot of angst, if anybody has ever experienced that. The other one is called hypoactive delirium, and they just basically sleep all day. They're no trouble at all. And in fact, you can kind of miss it because you just think, well, they're just tired and they're no trouble. So you just kind of leave them there, right? But that's a problem too. And we need to also address that. Or it could be, some people have both, right? They're falling asleep all day and falling asleep when you talk to them, but then they're hyper vigilant and awake all night and restless and trying to climb out of bed, right? So you can have both. So that's called mixed delirium. Okay, and so this, as I said before, is the Confusion Assessment Method, or the CAM. These are the CAM criteria. So it's 1 and 2 plus either 3 or 4. And these are typically used in the hospital, the emergency department, or the nursing home when somebody presents for evaluation when they're confused and somebody is concerned. However, what if the patient is an outpatient? Can we do the CAM on an outpatient? Yes, we can. And actually, you can even if they were, sometimes if they're cognitively intact.
Denise.
Okay, can you mute? Okay, so if they're at baseline cognitively intact and verbal and not critically ill, just a little bit off, sometimes it can be hard to pick up. And so there's something that somebody created called the ultra brief CAM, and it has increased sensitivity to pick up these types of patients with a baseline very mild or cognitively intact. And so how does this work? So this is the ultra brief CAM, and it's really quick, 2 minutes, right? There's just 3 questions. You ask the patient, have you felt confused in the last 24 hours? And if no, please tell me the months of the year backward. Let's start with December. And they go backwards. And then observe them. Does the patient appear sleepy and falls asleep during your interview? If the answer is no to all of these, then they don't have any delirium and you don't need to proceed to go to the CAM. So super quick, very easy to just ask 2 basic questions. And then 1 observation. However, if they are a little confused, if they are giving the wrong answers with regards to counting the months of the year backwards, or they are falling asleep, then the possible delirium, then you proceed to do the CAM evaluation, as I mentioned in the previous slides. There's an easy way to do it. There's actually an iPhone app or an Apple or an iPad called the Ultra Brief CAM Delirium tool. And so it's free. Just came out to 2023 and it's a free app and you can download it. And then basically it goes through the questions that you need to ask the patient or see. And you go click, 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 and it tells you delirium positive or delirium negative. So yeah, so if delirium is a possibility, it automatically goes to the CAM checklist and highlights each delirium feature, that's F1, 2, 3, and 4, and calculates whether or not the person has delirium. So I encourage you to go give it a try. Okay, and the other thing is that, early detection is really important. So it's important to tell caregivers to always look out for early warnings. This is called Stop and Watch early warning tool, which we use to teach our certified nursing assistants in nursing facilities or care homes. But yeah, these are things to look out for. Stop and watch. Do they seem different than usual? Are they talking or communicating less? Overall needing more help? Having pain that's new or worsening? Eating less? No bowel movement for 3 days or diarrhea? Drank less? Weight change? Agitated or nervous more than usual? Tired? There's a change in their color or condition and they need help with walking, transferring, toileting, all their ADLs. So yeah, these are the things that all caregivers need to just keep an eye out for. And they notice any of these things, they need to let the provider know that they're concerned. Okay, so what are the top, why do we need to let the providers know? Because these are the top 3 causes of delirium. Medications, drugs, especially anticholinergic drugs. Infection, like a urine infection, a pneumonia, or sepsis, a blood infection. Or abnormalities in the lab caused from anemia or dehydration, maybe the sodium or potassium's off, glucose or calcium, maybe their thyroid is also out of whack. And we need to start a medical workup right away. Other causes of delirium include things like stroke, heart attack, low oxygen, constipation or urinary retention. So these things are also very common and need to be looked into. And the treatment is to treat the underlying medical problem. Delirium is a reversible problem. So if you address the urinary tract infection, or you address the kidney stone, or you address whatever it is, that the constipation, and you take care of it, their cognitive status should clear up. That's why it's so urgent. And if you don't take care of it and you let it worsen, then their infection might turn to sepsis and they become critically ill and all that. So it's always better to catch things early. So that's why early recognition is really important. In the meantime, right, say this person has a urinary tract infection and you said, okay, that's fine. Here's some antibiotics, take 1 tablet twice a day, and, for 5 days and let me know how she goes. In the meantime, she's still agitated, right? So what's the family going to do? What are you going to tell them? Well, the approach is really, really important. And I'm just going to give you a couple of tips on the approach. So for agitated behaviors, this is called TADA, right? T stands for tolerate. If it's not dangerous, allow them to respond to the environment. If they're seeing things on the wall and it's not hurting them and it's not bothering all that much, just observe them. and you might actually get some clues as to what's upsetting them. They may tell you. A is anticipate. Behaviors are a way of communicating, and if they cannot tell you, you need to try to think ahead of them to meet their needs, to avoid the frustration or any dangers that may be coming up that they can't see. So it's kind of like a toddler. You got to look ahead and anticipate. Oh, I think they're going to be hungry. Oh, I think they need to use the bathroom. I think they need this or that. So anticipate. And then don't agitate. That's DA. If they can't reason or understand, don't try. So even reorienting them and telling them, oh, actually, don't you know, Mom, it's Monday. You know, it will make them frustrated and mad at you. Don't do it. If it doesn't bother them, that's fine. But if it bothers them, don't do it. Go with their flow. Try distraction. Try humoring, you know, the approach. Because this thing is short-lived. It should blow over. You know, just chill out, tolerate it, and don't make things worse. Okay. So what if they refuse to take the antibiotic, right? That's supposed to get them better, right? So we need to somehow get them to cooperate, right? So these are just a couple tools for that. So creating safety, right? When you are confused, you don't feel safe. You don't know what's going on, and you feel kind of uncertain, unsteady, and the patient has an urgent need to feel safe. So you need to make sure you create the atmosphere that is safe for them. So you need to be aware of your body language. How are you standing? Are your arms folded? Are you staring them down? Are you up high, low, down below? Look at be aware of your body language. Speak slowly and calmly. Show empathy and respect, and address their feelings. Don't need to address their, you know, all the nitty-gritty details. I think the most you should, but don't dismiss their feelings. Their feelings are very, very important and need to be addressed. You know, apologize. If they're accusing you of something, apologize and agree with them. Just back off and try again later. There's no need to argue, right? Create a safe place. You're a safe person. Show concern, right? You might say, well, yeah, I noticed you didn't eat breakfast this morning. Yeah. Can I do anything to help you feel more comfortable? And just listen and do not dismiss them. Don't say like, oh, no, that's nothing. You know, you're just imagining it. Don't dismiss them. That's just going to make them mad, right? And then personalize your approach. Don't do to them, do with them. So use a favorite drink, a favorite food. Oh yeah, they like orange juice, or they like apple juice, you know, take the meds with that. Or actually ice cream is better. Yeah, they love ice cream. Let's do the meds with ice cream, you know. Maybe they have a favorite person. You can get them on the phone and coax them into taking their medicine, right? Ask for permission. Don't demand them to take their medicine. Redirect them if they're going off the wrong way, right? Come back over here, or let's go to a better headspace where you're feeling more happy. Consider music therapy or gentle sensory stimulation in a personalized way, things that they, you know, will make them feel comforted. And then, of course, sometimes it gets beyond that and you still can't handle it, right? And he's like, doctor, give me some medicine because she's not letting me sleep, right? She's up all night and I haven't slept for the last 2 days and it's getting hard, right? So there are medicines that can be used for delirium. These are called antipsychotics. And they're typically used for the therapy of agitated delirium. And these are the typical classes that we often see. Maybe you've heard of some of these, like Haldol or olanzapine, quetiapine, risperidone, and lorazepam. They all have different doses. And I want to point out here is that these are pretty low doses. And actually, I even start off with even lower doses, especially if we got our little tiny, you know, 90-pound 90-year-olds, right? Then I even go with 0.125 or, you know, 1.25, half of these doses, right? And the selection of the type of antipsychotic will depend on the type of adverse events I would be concerned about. So if I think that they're not sleeping at night. I'll choose an antipsychotic that makes them sleepy. Yeah, so maybe we'll try Seroquel, right, which is quetiapine, and it's more sedating. But, problem with hypotension, low blood pressure, dropping with blood pressure. So somebody with low blood pressure, I wouldn't select that. But so that's why it kind of depends on the side effect profile, what types of things you might choose. Another sedating one is olanzapine, which is also a little bit more sedating, but it has fewer extrapyramidal side effects, which is like movement disorder kind of things. So yeah, so this is also something that you can consider if it gets really bad. And really, so the question is to medicate or not. I would tend to favor not medication. Okay, so antipsychotics and sedatives are only to be used as a last resort. If the patient is very distressed, I mean, they're like crying and sobbing and they're hysterical because there's a fire outside and they got to get out of here. Yes, use an antipsychotic because it's clearly distressing them, right? Or if they're in danger of hurting themselves or others, there's a difference between just, throwing a glass of water versus, ripping the TV off the wall and breaking, throwing and breaking things, right? So that if they're dangerous, they're hurting others, at risk of hurting themselves or others, then we really need to move to medications. Otherwise, try to do those non-pharmacologic approaches like TADA and comforting and just listening to them a little bit more and using a more personalized approach. And if their behaviors are dangerous, like I said, if they're like, ripping things off the wall and hurling furniture at you, then call 911, right? If the patient is really in danger, call 911. However, you should know that there are no geriatric psychiatry hospital beds in Hawaii. And admission may only be for medical workup. Once they've seen in the ER and they medical workup, they might just give them a couple of drugs and then just send them back out. So hospitalization or medications may or may not solve the problem because they're going to come right back home. And so a change in the approach is still the most effective intervention, and it's still going to be right in your lap, and you still have to figure out, how do I handle this delirium behaviors? So that's why it's really important to at least try that. Okay, next, I also wanted to talk about anticipating and preventing complications. Okay, so if they're on this antibiotic and they have, they just had pneumonia, they had the flu, COVID, whatever it is, right? And they're confused and they're talking a little bit crazy, right? You can't really treat it. They already finished the antibiotic or the antiviral, whatever it is. And it's just going to take time. It's just going to take time to get better. In fact, sometimes, so delirium often clears maybe a week after the treatment, but sometimes it may take 3 weeks. I've seen it take 3 months, 6 months. It could be a really long haul, right? And during that time of delirium, where they have these behaviors, may not be quite as severe, maybe lessening, but still they're declining. And what's going on? These are the potential complications that we're going to be seeing. And this is why this is what winds them ultimately requiring nursing home placement. And they didn't intend to. I mean, they were functioning independently at home before, and then after their UTI or their pneumonia, they just were never the same again, right? So yeah, they have potential complications of urinary incontinence, immobility, falls, pressure ulcers, sleep disturbance, poor nutrition, dehydration, aspiration, all those kinds of things. Those are the sequelae of delirium that people don't realize can wind them up for needing long-term nursing care. So we really need to let families and caregivers know that they should expect to provide supervision regular toileting, frequent repositioning, feeding assistance, and all of that until delirium is cleared. And it may take weeks to months. So they may need to get a doctor's note from you to have a family leave of absence or something like that to take care of their loved ones. Either that or placement in a nursing facility or skilled nursing in order to get all of this stuff, as their delirium may take a while to clear. So yeah, if they're developing urinary incontinence because they're just not remembering to use the bathroom, or they've gotten deconditioned from lying in bed for 3 days, you can get incredibly deconditioned, right? They're going to have incontinence. So take them to, you have to think about it. Let's get them to the toilet. Don't just say, oh, they're incontinent right now and that's it. So try scheduling toileting program. Try to get early mobilization, with assistance and with physical therapy. Don't let them do it by themselves, right? Pressure ulcers, need to monitor those pressure points frequently. This is especially for those people with the hypoactive delirium. They're no trouble at all. They lie there at risk for pressure ulcers on their sacrum and their back and things like that, right? Their heels, right? Sleep disturbances. So yeah, avoid sedatives because sometimes if you take a sedative and then they're sleeping like for the next 18 hours or 24 hours, avoid if possible, if at all possible, use it as a last resort. And then poor nutrition and hydration, right? Oftentimes these people need cues. They may be put in front of them, they may eat 2 bites and then they kind of trail off, right? So lots of cueing, lots of assistance if needed, aspiration precautions if needed, and then add supplements. Oftentimes what I see during these prolonged episodes of delirium is weight loss. And is confused and they're kind of zoning in and out. Yeah. And then let's see. And then also preventing functional decline. So cognitive reconditioning. So start, if they were cognitively intact before, start reorienting them to time, place, and person at least 3 times a day, if it's helpful. If it's not helpful, it's just agitating them, don't do it. But if it's helpful, put the cues up, put the clock right by, put the calendar right nearby, have a schedule on the wall, something to start getting them back into the groove of things. Monitor for depression, because depression will limit progress. How many times have I seen people in skilled nursing or just finished COVID or something like that, right? And they're depressed and then they don't do their PT because they're depressed, right? They don't think they'll ever get better, right? So monitor for depression and then, head it off. Schedule pleasurable events like behavioral activation. So find things that they can look forward to doing and start implementing that. And, if they need antidepressants, a screen with either PHQ-9 screen for it and then get treatment if needed. And ADL support, right? Their ability to perform ADLs and IADLs. So what happens when they get there? They need help, so you help them, right? And then you keep helping them, and it's a month later, and you're still helping them. Well, you know what? Sometimes then patients become dependent, even more, but than they need to be, right? So, as delirium reverses, the family can adapt to allow greater functioning and match their ability. So sometimes you can back off a little bit and test it out and see if they need it, and then back off and sort of see. And then finally, as I mentioned before, persistent delirium, family education. Like, it should not be a surprise to them that, gosh, it's a month later and they're still delirious. Yeah, sometimes delirium may persist and take a really long time to clear. Very small amount of people. Most people clear within 3 months. But I've seen people, they never are the same again. So families need to be aware of that. And so I also mentioned that they may need to consider long-term support for ADLs and IADLs, whether that means hiring a caregiver or whether to be at home with them or to have them be cared for in a care home or nursing home. Okay, so now I'd like to just open this up. I'm sure you guys have seen all these challenges. So I'm going to open this up for case discussion and questions. And I know that there's a bunch of stuff coming in the chat, so I'm going to just back out here and let somebody read off the chat questions for me. You're muted.
Sorry. For those people that are interested in getting that PowerPoint, that is available. When you registered, we have your email addresses. So one question, Dr. Nguyen, is how do medical comorbidities impact the person that's experiencing a delirium? If they have underlying diabetes,
Yeah,
vascular disease.
It's just got many more points of vulnerability. And typically what I see is that whichever is their weakest link, that's the one that's first to go. You know, so if their diabetes is really brittle and it's hard to control, you know, once they're in delirium, oh, it's going to be even wilder. You know, or if they were falling before and they were a little bit unsteady, that's going to be the big first one to go. So the more comorbidities, you have to really pay attention to their vulnerabilities and their comorbidities, and be extra on the lookout for those types of things.
Good to know. We have a comment from Naomi Orita. She said that some of the medications can or may be given sublingually. That makes it easier to administer if the person has dysphagia.
Yes.
Especially if they're not eating otherwise, like the antipsychotics haloperidol or azepam that's available in oral disintegrating form. You have any comments?
Thank you. Yes, that's
Naomi?
true. Those can be helpful.
Okay. And then Renata asks, is sleep when on a sedative restful and healing for that person that's dealing with their delirium? And her follow-up question is the PHQ-9, which is the depression screen. Is that valid during a delirious episode?
Okay, well, okay, let me see. Which one should I do first? I should do the question about, oh, sleep. Okay, so sleep, not getting sleep is terrible. I mean, you and I can't function well without sleep. So if you could find something, a sleep aid that is not anticholinergic, that's going to cause more confusion, and something that's not going to be too long acting and make them sleep for, 18, 24 hours, something small dose and mild, like melatonin, 3 milligrams, repeat again if that's just 3 or 6 milligrams, depending on what's needed, but use the minimum dose. If they are also delirious, a sedative, sedating antipsychotic like olanzapine or Seroquel. I tend to use those just at nighttime for a season, maybe for a couple of weeks or something like that, a small dose, and see if that will just help support their sleep and help organize their brain a little bit. And then eventually back off those things. So yeah, sometimes those things can really help. And oh man, the value of a good night's sleep, that's really important. It's good for everybody. So if needed, but it should not be a long-term solution. And if you need a long-term solution for sleep, use one of the non-antipsychotics. So is
the depression screen?
Yeah,
the validity of the depression screen.
Yeah, so what about the validity of the depression screen for people with advanced dementia also doesn't work, right? So you really actually have to assess their dementia first. And if they are not if they can make themselves understood and they can express themselves, then you can use the PHQ-9. But if not, then you just have to go on observation. And
then Naomi has talking about, again, the severity of some of the comorbidities and medications which person may be taking. They may increase the risk of delirium. It's really too broad a question to answer specifically. And
Yeah.
that's a good point, well taken.
yeah,
So I do have a case. I had a case situation,
Ooh.
a couple of cases in adult daycare where this relatively very cheerful, outgoing client would always come, in the mornings, and she would greet all the other participants. And one day, and this happened for like, I guess the whole day, she wouldn't talk. She would just sit there in the chair and she would look, and then she started crying, sort of, and nobody could console her. And we couldn't console with the meals. Even at mealtime, she wouldn't eat. So finally, we called the caregiver, and lo and behold, they found out she had a urinary tract infection, right? And we just thought maybe we thought she was depressed and something had happened at home with a caregiver, but it was wise. It was, really prudent on the caregiver's part to take her to see the doctor. And they did some lab work, and they went, wow. And within like 2 days for her, we saw a significant change in mood. She obviously didn't remember crying and being out of sorts, but those are really good points, because we often just think of delirium in terms of being more like the agitated behavior, the challenging kinds of behaviors where they're combative, agitated, restless. But that was really interesting to see somebody just withdraw and cry. Ooh. I don't know, does anybody else have cases or situations they want to share? I think I saw Dr. Buffenstein.
I'm sure you guys have seen stuff like this.
Hello? You dragging me
You're
in?
on the hot seat, Dr. Buffenstein.
Well, what was the question?
No, we were just wondering if you had any good cases of sort of examples of delirium and the challenges of managing that.
Well, I just agreed with a couple of the things you said, that first of all, the chain always breaks at the weaker link. So really what you find with people is that if they're falling, the falls get worse, the problems get worse. And the comorbidities and the polypharmacy is like a huge issue. And having people, my own experience, I think I have an 88-year-old guy now who gets hypoxemia and has hypertension and has a borderline personality disorder. And when he starts to decompensate, his issues come back. So one of his issues is that he always threatens the care home givers that he doesn't like them, they don't care about him, he wants to leave, he wants to move, he's going to commit suicide if they don't help him, and so on. And it really becomes aggravated. I guess delirium is part of it, distress is part of it. The point of the story being if he goes to the emergency room, there's no way to admit him. And so then it gets back to the care home operator calling me and saying, well, he's sundowning, and at night he's not sleeping, and he's yelling, and he's got nowhere to go, and so on. Would I medicate him? And it just happens so often, all the time, that it ends up across my purview that I'm getting asked for sedatives that really accelerate end-of-life issues, and it becomes sad. And I feel bad about it, putting people on these sedating drugs when they have, respiratory compromise and so on. And I know that it's going to put them at high risk for, pneumonia, death, immobility, cardiac arrest, and so on. And yet all we kind of keep doing is layering more and more, pharmacology on these people. We end up with polypharmacy. It's really kind of a problem. It's a problem across the board.
Oh, wow.
The other,
Thanks so much. Yeah.
the other issue, of course, is the use of antidepressants in patients who have both delirium and dementia and who look depressed and so on. My own 2 cents experience is that most of the time antidepressants make it worse. And that really what you end up with the person who has delirium or dementia and who's got depression and labilities, you end up with an agitated person who's got delirium and dementia with worse agitation and worse kind of symptoms. So, I guess that's another kind of precautionary measure. But all of the things that you mentioned, work together: the social support, the caring family, the visiting nurse, the medical assessment, the control of the blood pressure, the psychiatrist, if they're not harmful, all of those things. So I guess that's my 2 cents worth.
Thank you for
Hi, Dr.
underlying all of those
Buffenstein.
issues. Yes.
I'm sorry. Do you find, Dr. Buffenstein and Dr. Wen, that oftentimes that delirium is underdiagnosed or misdiagnosed, and people are just written off, as this person, it must be because they're old, or it must be that they're getting demented. I mean, what has been your experiences and response to that, if people are not being accurately diagnosed, or I think underdiagnosed?
No, absolutely. I think especially, I mean, the agitated delirium, that's kind of, everybody does something about that, right? It's the hypoactive delirium that people just miss the boat on. And those are the ones that really decline. Veronica says, during her nursing career, I have seen delirium to elderly most after giving Haldol. So we are so careful giving elderly patients with Haldol, or much possible try to reassess the situation before giving Haldol to the elderly. Yeah, I that's why I said before, meds don't fix everything. Meds often make things worse, which is why you have to have all the tools and the creativity to figure out how to approach them differently and really maximize the non-pharmacologic strategies. And I think the hugest thing is education of the families, so that they know what to expect and know how they can help, because sometimes they're the ones that can help better than we can. That's why we call the families sometimes, to get them to join us and partner with us. So it's crucial. It's just, I don't know, I see many of you here, we've been partners taking care of many of our patients, and it's sad. I often see people, after an episode of delirium due to infection or some kind of illness in the hospital, they never quite recover, and they go on this spiral of functional and cognitive decline, right? Which doesn't have to be that way.
What's your estimate of mortality post episode of delirium? We see a lot more of those people die sooner. I think delirium has actually a high mortality over 6 months to a year. A lot of people are very much weakened by it, and that's what I kind of see. I see people get very much weakened after they go through episodes of delirium. Addressing your issues about diagnosis, I find it very difficult to diagnose delirium too. So I guess there's other people find that equally difficult. And it's taken the time to take a careful history, and then to look carefully at your exam and your labs and so on, and to think about it, to always think about it.
Yeah, thank
We
you.
had a comment about lorazepam, that it's notorious for causing delirium, and Renata also says benzos increase memory loss, aggravating the dementia. So great comments.
Yeah, in fact, right, it can cause even greater disinhibition. And so whatever was bad, and by the time, all it does is sedate them. And then once the sedation wears off, bam, they come back with a vengeance, and they're like crazier than ever. So it can aggravate things. So I avoid them
Remember,
unless they have, alcohol withdrawal.
remember the issue of benzodiazepines. It's a very it's a very germane issue, because I think that we all think that benzodiazepines are bad, and I think they generally are bad. I think they're destructive. If a person is chronically taking benzodiazepines, then to take them off benzodiazepines in any kind of unsupervised manner can be very risky, and sometimes it's just not worth that kind of journey. Certainly benzodiazepines are increasing the risk of fall and confusion and so on. It sort of depends a lot on what the patient's history is, and how much experience they've had with benzodiazepine. In terms of just acute sedation or acute calming a person down, in episodes, that's fine. The problem comes when you start using it every day. And then the body develops tolerance and produces symptoms when the benzodiazepine is absent and so on.
Yes.
So it's a question of, the hammer is only as good as the hand that wields it. And really with that particular tool and so on, you have to be very cautious about, about how you prescribe it, but can be useful, especially in people who are not naive to that medication in more ongoing treatments and also in acute circumstances. The antipsychotics, they're very strong, and most of them carry black box warnings about, not to use in dementia and so on. And depending, I guess, on the toxicity of the agent causing the delirium, most of our folks who have delirium have a degree of dementia and have a weakened resilience, and that's kind of what's going on. So I think we do see an increase, in problems using antipsychotics as well, and that's why we try to stay away from most medications.
Yeah, I wanted to just jump off of what Naomi, of the question of mortality and delirium again, because in my experience, a lot of these guys wind up on hospice. I just wanted to get your sense, Naomi. I know you're in hospice. How many times do you see that? How often do you see this as a cause for going on to hospice?
Yeah, hi, Aida. So can you repeat your question, please?
Oh, how frequently do you see people signing on to hospice after episode of delirium?
Oh, I can't estimate how often that occurs, because if anybody's going to come in with coincident delirium, it's going to be someone, I'm just going to say anecdotally, someone who has had a prolonged illness, and with the coincident delirium from their primary conditions that they have persistent, they have to fulfill the criteria for hospice. So there's a whole, and someone with just plain old delirium, they would have to fulfill criteria of the different disease conditions, or if it's a non-specific, it would be like weight loss,
Right.
aspiration,
Debility. Yeah.
debilitous wounds, etc.
Yeah.
So they have to come in with a different, overall a different condition usually.
Yeah, no, that's kind of what I was sort of getting at, because I see people coming in with their malnutrition, debility, weight loss, and they pressure ulcers, because they also need increased care at home too, and then the family and the caregivers cannot adapt to that either, and then they wind up declining, seriously going down to like 68 pounds or pressure ulcers.
Correct. And I learned recently, this is really great for me. Here I am, I've been in this career for a long time, but even just about 3 months ago, Dr. Boer Wong put out a really great article about how some of the medications, we think maybe the half-life might be a day or two at most, or maybe even a few days. Sometimes given an older person, because of the decrease in metabolism, that the persistent effects causing delirium can persist for even up to a month or several months, which is really astounding. So things to think about, that I need to think about as well, that I didn't know, I didn't realize before. So for all of us to be aware of.
We all need to be reminded too sometimes.
Aida, there's a
Yeah,
question
but
in the
thank you
chat
so much
box
for this
too,
most excellent talk.
from Renata about vitamin panels. Do they help decrease delirium, thiamine, etc.?
Well, I suppose if they have a deficiency, that would help. It's part of the dementia workup. I'm not sure about the evidence. I don't know if anybody else has experience with that. Maybe they can chime in. All right, well, it's something we're gonna have to look up then. Write that down.
What about antibiotics? I had a situation, Dr. Wen, where my mother-in-law was taking eye drops, and lo and behold, we went to see her the following morning to bring her breakfast, and she was flat on the floor, face down. And the newspapers, the magazine were strewn all over the place. She had tripped over the footstool, and she was still, she wasn't hurt. Fortunately, she wasn't seriously hurt. And when we asked her what happened, she goes, "They were here last night. You weren't here." So she was having these hallucinations. She kept this, and she had to I had to try to get them out of my house. So she threw the books up. I threw the books at them, the newspapers, and they finally left the house. So at that time, I didn't know much. So I called Dr. China. I worked with, he goes, "I think you should take your mother-in-law to the ED." And again, they did the workup, they looked at her. This was just very odd for her to do this. And the only thing recent that had been started was some antibiotics for eye drops. They stopped it like within 24 hours. Boom, a totally different person. So yes, sometimes it does. I've seen where it goes on for weeks, but then there's unbelievably some dramatic changes with people if you catch it, I guess, early on, whatever the
Absolutely.
catalyst or the thing was that caused.
Yeah, sometimes some antibiotics, some pain medications, some NSAIDs, like over the counter even, some, of course, anticholinergic medications can all precipitate delirium. So in fact, drugs is the #1 cause of delirium. It's in the top 3. So they got delirium, you gotta look at their med list and say, what was recently started? And could it be accumulating? Yeah.
Any last minute thoughts or comments from people that are attending today? Dr. Khan?
You always have good questions. Yeah.
I think the biggest offenders, which is really problematic, is the over-the-counter antihistamines, like
Yes.
Benadryl. People don't realize that it really is a problematic medication, and it's so readily available. And people are taking in their, zombies the next day, or people are falling down. So that's one of the things that we really need to share that information broadly about the dangers of a lot of the OTC medications.
Mm-hmm. Yeah, like those antihistamines people take for itching and dizziness, right? That they can just get over the counter. Great. Any other stories? Okay. Oh, Sarah, are you speaking? You need to unmute.
I am sorry about this. Thank you, everyone. And, we look forward to you joining us in July. Just as a reminder, you can see the evaluation link that's in the chat. So you can fill out that form kindly to receive your CMEs and social work CEUs. Thank you, everyone, and have a great week.
Thank you.